at the bottom. Okay. So hematologic emergencies or bleeding type emergencies, again, just like all the medical emergencies, do that good patient assessment, okay? Otherwise, you just have to really recognize what it is. Anemia. Anybody know anybody with anemia?
Oh, yeah.
All right. Reduction in red blood cells, right? So they don't have enough red blood cells. Why is that a problem?
That's less available oxygen.
Yeah, can't carry oxygen, right? That would be a problem. So anemic, you can't give blood when you're anemic. Okay, you get anemic. Maybe they have a bleed somewhere, so they could become anemic. Right? You're going to notice this patient just the paleness, right? Lack of energy, decrease in pressure. No, not really. You know, cells, blood cells, pressure is probably going to be okay. They could have a pressure problem if it's long term. All right. Anyway, most of the time it's going to be chronic. They have a history of it. Just like it says, pale, fatigues, easy. They're not getting enough oxygen. They're the hemoglobin's not carrying the oxygen. There's no bus to transport it. So no red blood cell. So anemic patients, okay, strictly here the same thing. Support their airway, maintain their airway, evaluate the need for oxygen, do good patient assessment. Take them where? To what hospital? What kind of hospital? You want to give them blood, right? Yeah, which is all of them. So no problem there. Sickle cell anemia is where anybody know anybody with sickle cell? Yeah. So it's the sort of an odd shape. The cell itself becomes odd shaped. The hemoglobin, the red blood cell, the normal red blood cell has a very distinct shape to it. That hemoglobin fits on there in a very distinct way, okay? Then oxygen attaches to that hemoglobin. Well, if the red blood cell is not shaped correctly, one, it's going to snag and it's going to cause clotting problems, okay? But two, it's not going to transport oxygen correctly either. So there's going to be a problem. They'll have a history of sickle cell. This is something that they're diagnosed with. But it says here in the book, African Americans, Mediterranean, South and Central American, Caribbean, Middle Eastern origin. Okay, they're sort of historic with sickle cell anemia. It is a huge problem. They are in a lot of pain. Nothing to joke around with. They're in a lot of pain. So you would take them there where they have a sickle cell crisis. Just like it says, they could have a bone crisis, chest syndrome, abdominal pain, joint pain. All right, a number of these in a sudden onset. So, but they will know. They tell you, yeah, I have sickle cell, and they're going to tell you, hey, I'm having a sickle cell crisis, right? They're going to be able to explain that to you. Same way, really, that anemic patient, most of the time if that's chronic, they're going to be able to tell you that, hey, I have anemia, I'm having problems with that. Hemophilia, or a bleeder, right? They have a bleeding disorder. They either don't have any or a very low clotting factor where they tend to bleed. These patients, even the scrape, they will bleed a lot. So again, past medical history, they have a history of bleeding. A thrombus or a DVT, deep vein thrombus. What's a thrombus? Yeah, you're right. So thrombus it's a clot, but it didn't move. It originated there. An embolism is one that moves from one location to another. So it moves from the origin to another location. This DVT, I mean, people get them all the time. Poor circulation, extended airline trips, you risk DVTs or a thrombus. That's why when we do our good patient assessment, we feel the legs and make sure the temperatures are equal in the legs, correct? But that's what they would have. They have some sort of circulation problem, swelling, pitting edema, tenderness, real tender to palpation. All right? And then sort of the telltale sign, though, is the change in temperature. That one extremity with the DVT or thrombus in it is going to be cold or cooler. It's not going to be as warm as the other extremity, both arms and legs, right? So there's not a great deal of these. The DVTs can be sort of a sudden in onset, especially, I mean, not like boom right away, but you know, this guy's been on a 14-hour flight. That's still pretty sudden in onset. Those things. That's why they tell you to get up and walk around on that long airplane ride to prevent that. Again, just identifying, making sure that you take them to the appropriate facility. Okay. Any questions there? Everybody good? Urology. I don't know how to say that. How do you say that? Genitourinary. Somebody help me out here. 719. We skipped over that one. How do you say that? Genitourinary? I'm good. So people with renal problems, okay, renal issues, renal emergencies. Now this is different. Well, in a sense, not really. You have the kidneys, right? So that could be part of the problem. You have the urinary tract. So you have the kidneys, the ureters, the bladder, and the urethra, correct? So you could run into any problems in between that. Men could have problems with the prostate, right? Swelling prostate gland, and most of it's going to be with most of these problems are going to be a flow of urine. So you're going to have a problem. The person has trouble urinating, or the person has burning when it urinates, right? Like with the UTI, urinary tract infection. So we look at that, a UTI, a bad UTI, we just seen one the other day in the hospital, causes all kinds of altered mental status, crazy altered mental status. Okay, so they would look at that, they'd draw some labs for that. So you have that patient that has that normal glucose level and they're still really altered. Think about that. But you're not going to be able to get that you're not going to really get the information that you need out of that patient, right? That altered patient. So you might have to ask other, I don't know who would know that, maybe a spouse or something would know. Maybe they have a UTI. Like, what would you be looking for? Let's say you had this patient that was really super altered and they couldn't answer any questions, but their spouse was there. Either one could go, the scenario could go either way. What questions could you ask that spouse to rule out this UTI? Yeah? Is he urinating okay? Urinating, most of the time, especially older couples, they know when each other, they go to the bathroom, they get up, they go to the bathroom, they come sit back down, right? So, are they urinating enough? Are they urinating correctly, right? What other things that you think a spouse might know?
They're diabetic.
Yeah, that medical history, right? What else? But with the urinary tract, you're working on this urinary tract thing. Do they have a problem?
Any history of a UTI?
Yeah. History always repeats itself. Okay, that's good. History of UTI. What do you think people have with their urine that have UTIs? How's their urine look?
Oh,
Huh?
if there's
Cloudy,
blood in your pee.
Blood, cloudy, concentration, smell. That spouses don't know about that. You know, oh yeah, their urine's really concentrated, it really smells bad. You know, they flush the toilet and 5 minutes later I can still smell the urine in the bathroom. The spouse is going to know about that, okay? So those are questions that you can ask them that sort of leads in, yeah, maybe this person is having a UTI. Okay? Blood in the urine, right? Pus, anything else, flank pain. Then the dreaded kidney stone. Has anybody ever had a kidney stone?
No, my dog had one.
Dog. Oh.
Dog.
Poor puppy. No. But I know some guys who have had kidney stones before. I mean, big burly guys, you know, that you're thinking, oh, they're pretty tough guys. Took them down like a baby. I mean, let me draw them. So you have your kidneys, your ureters. Looks like a too much for Friday, huh? Okay. Your ureters. What would this be? Bladder. And then the urethra. Okay, I'm sure you guys knew that. But the stone releases from inside the kidneys and travels down the ureter, and every time it's not perfect and round. It's like a piece of ice. If you take a piece of ice and you throw it on the ground, you pick up little fragments of it. It's all sharp and everything. Those kidney stones, every time that this patient produces urine, which is constant, okay, constantly sort of pushing urine out there, it pushes that stone down that ureter like that. Then it pauses, and so produce more urine, and it goes pauses. So the pain is what?
Episodic?
Well, almost spasmodic, because as the urine flows, the stone stops a little bit, so they'll be going, ooh, that really hurts. And I don't know why, but this is true. The patient will bend over like this, and that gives them some relief. Otherwise, they need a drug called Toradol, and it's not a very powerful medication, but it relaxes that ureter. I wanted to say something else. But it relaxes that, okay? So, but they'll bend over, and then that stone will move a little bit, and then the pain will hit them again, and move a little bit, and that pain will hit it again. That, or worst case scenarios, it gets clogged up in the kidney itself, so they have to go in and break it apart, okay? Or it gets stuck in the ureter, and then they have to go in there and break it up. That's very painful, because then the patient can't pass urine out of that one side. So it becomes very painful. So that's kidney stone. Retroperitoneal pain in the flanks. So it's going to be classic. Those signs and symptoms of a kidney stone are classic. The patient usually has a history of them. Okay? And then they're bent over. You go in their house and they're bent over like this, and they're saying, oh, it hurts bad. Like 10 out of 10. Right here in my flanks. And then just, you ask trouble about, do you have a history of kidney stones? You have had trouble urinating? Those type of things. And then once they get that flank pain, it's almost always if it's not muscular, it's almost always a kidney stone. All right. What about a bladder? What about the bladder? Bladder infection? You may have had a bladder infection. One thing with bladder infections is holding your urine too long. That's why you can say, hey, I'm going to the bathroom, I don't want a bladder infection, right? But you hold your urine too long, or you don't have, you're just not urinating at a proper, the patient's not urinating at a proper rate or time, you know, they're sort of slow with it, they're retaining urine, it can cause some infection, bleeding. The bladder will start to bleed, so you get blood in your urine. It's usually a sign of and it's going to burn because the blood is a little acidic, and so as it goes through the urethra, it's going to light them up somewhat. Okay, and then anywhere here is an infection anywhere here, not in the bladder because that's a bladder infection, but in the tract can be the UTI. You guys want to picture that before we? You good? Man, I figured you'd use it to study your anatomy a little bit. I don't guess so. All right. Kidney failure is big. It's people with kidney failure go into dialysis. Run a lot of dialysis patients. If there's a dialysis facility in town, which here there's plenty. Okay, dialysis patients can be really critical. They can crash really fast. Have a lot of pressure problems because their kidneys are not working. They have to take the blood out, filter it, and put it back in. Right. And if you happen to work for a transfer service, you may pick up a lot of dialysis patients. Okay. One thing big about the dialysis patients that we sort of need to know about vital signs is the shunts. If they have a peripheral shunt, like in the arm, you can't do a blood pressure there. That urologist will be really mad at you if you blow up their shunt. Okay, so no pressures in the. So you can feel the shunts in their arm, in their forearm. Looks like a piece of rubber tubing in there. You can feel them. If they're conscious, they're going to tell you, hey, you can't take a pressure there. I have a shunt. All right? But keep that in mind, that hey, you can't take a pressure where there's a shunt. There's a peritoneal shunt, like in the abdomen. Sometimes they get dialysis through a peritoneal shunt. Okay, so you can use the extremities. But dialysis is an all-day process. These guys who take them to dialysis, they pack a lunch. And they sit there and there are little TVs in front of them. Have you ever been to a dialysis center? They watch movies all day while they're doing dialysis. They filter the blood and put it back in. You can have a lot of bleeding from the site, from the graft, where they've done the dialysis. Okay. And then they can get into a lot of pressure problems if they don't hydrate them properly. Again. So there's a lot of problems. There's the list: hypotension, cramps, peritonitis, nausea, vomiting, hemorrhage from the site, infection, cardiac arrest would come in the dialysis patients would come very quickly. And then septic, and a lot of times you pick them up, they have difficulty breathing. But you'll probably run into these, especially during your clinical time on the ambulance. Just look if they say, oh, I'm in renal failure, then look for the shunt or ask where the shunt is before you start doing the blood pressures. The last thing that you sort of have to worry about is indwelling catheters. We learned about that during your PCT training, correct? The people who have urinary Foley catheters, they're indwelling, they live there, so they have them at their house. They always have a catheter. And one thing to look for in the catheters when you go up and you're doing your assessment is the color of urine. Okay? Are they urinating? Are they producing urine? Do they, is it painful for them? Usually not, because it doesn't go through the tract. The urinary indwelling catheter goes directly into the bladder. Alright? But it can get infected. There's a lot of infection related to the catheter, the urinary catheters. So there could be infection around the site, could be a urinary, like a bladder type infection. Okay. One thing that you want to make sure that you're really paying some attention to is the catheter. Don't be picking the patient up and moving the catheter and leaving the catheter bag hanging. Right? So you have the catheter bag. Let's say Steve over here had a urinary catheter, and you go to move Steve over, and you forget the urinary bag, the catheter bag on the side of the bed. So when you move Steve over, you pull the catheter out. I think it's 30 cc's or 20 cc's. They put 20 cc's of water. They put the catheter in. And you guys seen how the catheter's done, right? And so they put the catheter in, and they put the water to blow the balloon up to keep the catheter in. So if you pull the catheter out, you pull all that fluid down the urethra. It can cause a lot of trauma to there. Okay, so look for that. Look for the catheter bag. If they're conscious at all, they're going to be like, "Hey, my Foley's over here. My urinary bag's over here." Okay. So make sure that is up and out of the way. Otherwise, they're your good, great patient assessments. Questions? Concerns? Ready for your break? Long break, week long break. All right.